So one of the fun things for me about being the moderator of this conference every year is to introduce people that we've come to know in the field of pain science. And Jason Kutch is someone that we met a while ago in the MAP network. And it's been really fun to meet and work with Jason. We didn't know when we started working with him at the MAP network that he actually spent a bit of time at the University of Michigan. He got his PhD here in mathematics. Jason has a very eclectic background in a good way. He has an engineering background. He's in a department of physical therapy. One of the things you won't see on his written bio, I hate reading written bios and I try to avoid doing that, is that he is a surfer and he's used surfing as a therapy for people with chronic pain. So I don't think he's going to talk at all about that today, but you are? Okay, perfect. All right, wonderful. Jason, please.
Hi, everyone. It's such a delight to be here, and I really want to thank the CPFRC, the organizing committee, Dan, Andrew, all of the colleagues here. I did do my PhD here at the University of Michigan, and this is my 20th wedding anniversary this year. I was married in the Michigan League right across the street, so Ann Arbor is a very special place for me, and I'm super happy to be back. And I absolutely love this meeting. I think it's just a fantastic opportunity. I was here 2 years ago to interact with some of the great minds in the pain field, to get to interact with patients with lived experience, and it really brings everybody together in a really unique and special way. So I'm going to talk today about some work in my lab on the neural mechanism of chronic overlapping pain conditions, and then I'm going to link it with some work that I'm currently doing in immersive virtual reality to try to modify those signals and hopefully have a positive impact on pain. So chronic overlapping pain conditions, no surprise to this audience, are recognized as an important contributor to reduced quality of life in chronic pain, as well as a predictor of worse outcomes for many treatments. And to start to kind of turn the table on this, we want to have objective biomarkers of COPCs, try to understand where they're coming from a deep neural perspective, and then really try to tailor treatments that will work specifically for folks with COPCs. And so in order to do that, what I'd like to be able to do is to create a testable theoretical model for neural dysfunction in COPCs. What is it? A simple biomarker for neural dysfunction in COPCs that is really linked to that theory, and then a systematic approach to find the best way to modify that biomarker to really reduce the burden of COPCs. And that could take a lot of forms. It could be reducing the duration of flare-up. It could be reducing symptom intensities more broadly. There's lots of ways that we could conceptualize reducing the burden of COPCs. So as Dan hinted yesterday, I got into this field because I developed a lot of COPCs myself. To make it easy to remember, they showed up in even 2-year increments, ranging from 2001 to 2007. And what I do when I have the opportunity to speak to the public and get the message out about COPCs is I use the opportunity to tell my story to get people to recognize that these are overlapping pain conditions. They may be indicative of an underlying disease process that we're only starting to understand, but that there is substantial hope for improving quality of life in these conditions. So I think that I've always tried to use my personal experience, and it's been an interesting process to try to merge personal experience and my skepticism as a scientist. And I think what I've tried to do in that realm is be careful not to overgeneralize my experience and to use it more just as the impetus to know the importance of what I'm studying and to think of interesting ways to study it. But I do want to make a kind of a comment about my specific case and perhaps a general observation from that. So the full spatial pattern of chronic overlapping pain conditions across the body is quite complex and I don't think very well explained by sensitization across multiple spinal segments. And so As I mentioned in the previous slide, I developed migraine in about 2003 and then chronic pelvic pain in about 2007. And so when I started collaborating with the MAP Research Network, I was drawn to this notion of studying body maps and understanding the spatial distribution of chronic overlapping pain conditions. Because when you experience it, it doesn't make a lot of sense. Like, why is my head hurting today and my abdomen hurting tomorrow? They seem so different from one another. And sure enough, in the MAP Research Network, I don't know if I have a laser pointer here. You have, if you map, and Dan showed this a little bit yesterday, if you take chronic pelvic pain patients and you map it out across, the map body pain across the body surface, as pain becomes more widespread, it doesn't do so uniformly. And so it will show up in the abdomen, pelvis, and low back and head to a greater intensity than the rest of the body, and that intensifies even further as pain becomes more widespread. And that was validated by multiple independent cohorts. And it's just not obvious how to explain that with simple dermatomal spread across a couple of spinal segments. And so it really kind of hints at supraspinal involvement and contribution to COPCs. So in this paper that I collaborated with Rick Harris on a number of years ago, and Dan showed this yesterday, kind of pointed to the salience network as a key contributor to chronic overlapping pain conditions. And then Chelsea Kaplan's work sort of beautifully shows that this may even predate the appearance of chronic pain in adolescence. But I really wanted to interrogate the salience network further and really try to understand what are the key elements and what are like the neuroanatomical connections that may be underlying COPCs. A postdoc in my lab, Amy Haggerty, a couple of years ago did a really nice mapping study of the salience network and pulled it apart in a little bit greater detail. In multiple cohorts, you can see that one of the key elements of the salience network is the thalamus. And so what I want to talk to you today a lot about is the potential role that the thalamus may play in chronic overlapping pain conditions. So what's cool about the thalamus is neuroanatomically, that's where these projections, ascending projections from the somatosensory system and from the face converge. So the information ascending the anterolateral system and the spinal thalamic tract hit a series of thalamic nuclei before they project and really form a lot of the salience network through their projections to the cingulate cortex and to the insular cortex. The information from the face is coming in through the trigeminal pathways, so it's kind of different neuroanatomically, but it converges at the thalamus. If you look at the thalamus in 3D, which it will hopefully spin around here a little bit. If we this is the back, the posterior end of the thalamus. These are the different thalamic nuclei that are rendered for you in 3D. This is the anterior end of the thalamus that's coming into view. So the areas of the thalamus, the VPL that represents the body is right here, and the VPM that represents the face is right here. Just posterior to those two nuclei are a whole series of nuclei that encode other sensory information, like the lateral geniculate nucleus, projecting to the occipital cortex for the perception of light, the visual system. Right next to that is the medial geniculate nucleus that encodes information that goes to from the ear to the auditory cortex. There's a tremendous amount of convergence of sensory and pain information in the thalamus that then widely diverges across the brain. So when we're talking in COPCs about multiple sensory sensitivity and pain sensitivity, it just kind of screams thalamus. And lots of researchers have obviously studied thalamus in the context of chronic pain, but I don't think it's received as much attention as perhaps it should have specifically for COPCs. So I'd like to develop that a little bit further. So how do we detect what's going on in the thalamus? Is there an easy way to do it? So if you look at EEG signals from across the cortex, they have a very, very dominant peak in the frequency band at around 10 hertz. This is called the alpha peak. And a large number of studies have demonstrated the critical role of the thalamus in generating the alpha rhythm. And so Dave Semenovich and his group has spent a lot of time understanding the role that the peak alpha frequency, or the frequency at which the alpha band has its peak, which varies in different individuals from about 9 hertz up to 11 hertz. It's very stable within it's relatively stable within a given individual. And what Dave has shown is that the inter-individual differences in peak alpha frequency in otherwise healthy individuals predicts the degree of pain sensitivity that that person will express to quantitative sensory testing tasks. So the higher your peak alpha frequency, the less pain sensitive you are, and the lower your peak alpha frequency, the more pain sensitive you are. And kind of a seminal study by Sarthen et al. In 2006, which took, I believe it was 7 chronic pain patients and actually did surgical ablation of part of the thalamus for therapeutic purposes, showed that there was a shift in peak alpha frequency from lower peak alpha frequency before surgery. Peak alpha frequency was still low just after surgery, but I believe it was 6 or 9 months later, when pain resolved to quite a substantial degree, there was also a shift in peak alpha frequency upward towards that of a healthy control. So here in this case, it's very clear evidence if you take out the thalamus, if you remove the thalamus, peak alpha frequency will go up. If you're more sensitive to pain, peak alpha frequency will go down. So it gives this kind of speculation that low peak alpha frequency is indicative of a thalamus that has very strong control over the cortex. And higher peak alpha frequency indicates a little bit more disconnection between the thalamus and the cortex in probably a good way. So Natalie McLean, who's here today and was a PhD student in my lab, is now as a postdoc at CPFRC. Did some studies a couple of years ago in my lab mapping the neural correlates of peak alpha frequency in healthy individuals, and found some really nice findings both in the thalamus and also across different pain-related regions such as the anterior cingulate and secondary somatosensory cortex and the insula. I'm really grateful to Natalie because she kind of independently discovered this whole field of peak alpha frequency and came to a lab meeting one day and was like, hey, you should probably start looking at this. It looks very interesting. And that's just really a great experience as a mentor when the PhD student pushes you in a whole new direction. So that was really exciting. Natalie, together with Rocco Cavallari, who was a Fulbright scholar from Australia that came to my lab last year, did this study that I'll take you through, which is the first, to my knowledge, that looked at peak alpha frequency related to chronic overlapping pain conditions. And so since COPCs are often associated with increased pain sensitivity, and increased pain sensitivity is often associated with people that have lower peak alpha frequency, we hypothesized that more COPCs would be associated with lower peak alpha frequency. And to account for the effects of sex, we kind of took 2 studies that were going on in my lab. I had a previous study that was funded in chronic prostatitis, so men with urologic pelvic pain conditions, in which we had body maps, and then an ongoing clinical trial that I'm running for repetitive transcranial magnetic stimulation in women with interstitial cystitis. And so we took the baseline data from that clinical trial and put it together with the earlier observational study and matched. The clinical trial used the COPC screener that Andrew and colleagues developed. The previous study used the BPI body map. We did a little harmonization of those 2 body maps just to put them in the common framework of the COPC screener, and selected a set of males to match with the females so that we would have an equal balance of sex, and there'd be matched between the individuals with more localized pain, fewer COPCs, and those with more widespread pain or more COPCs. These are roughly what the body maps would look like for the more localized versus the more widespread group. Here's the clinical demographics. The only thing to note here is that I don't know if it's a peculiarity of our sample, but something to bear in mind is that our local pain group and our widespread pain group were actually relatively well matched for anxiety and depression, which is not something that you would ordinarily expect. You would ordinarily expect more COPCs to be associated with a little bit more depression, but maybe it's just the benefit of the sample that we have. We were able to kind of isolate out that effect. So there's those two groups are matched for sex, they're matched for age, and they also are turned out to be not different in anxiety and depression. So we found a large and statistically significant effect in the direction that we expected for peak alpha frequency. The patients with widespread pain had significantly lower peak alpha frequency compared to the patients with widespread pain. And just some examples here from, this is an individual with low peak alpha frequency and more widespread pain. You can see these different graphs are across different channels of the EEG. We're recording from 64 different locations across the scalp. It's pretty consistent across the whole scalp. There wasn't a ton of variation across the scalp. Here's a person with high peak alpha frequency, again, pretty consistent across the scalp. But if you dig in a little bit deeper and you look for where were the statistically strongest effects of peak alpha frequency across the scalp, a very cool picture emerges, which is this. So here is a whole scalp map of where we saw the greatest changes in peak alpha frequency. So you can see there, this is basically widespread compared to localized. So a negative value here means that there's a greater decrease in the widespread group compared to the more localized group. And so these spots that pop out here are areas where there's kind of the greatest difference. And we see somatosensory cortex here and occipital cortex here, which is really interesting for two reasons. One, there's kind of like this slight left shift in sensory motor cortex, which lines really well with what we found in MAP. But two, that there are changes not only in regions that you would think are associated with pain, but regions of the occipital cortex that you would think would be associated with sensitivity to light. So maybe other sensory modalities as well. Okay, so here's the theoretical model that emerges for me about what's going on here. We have sensory input from classically non-painful sensory modalities, such as vision. That is converging on areas of the thalamus and then projecting to certain areas of cortex. We have ascending nociceptive and non-nociceptive information coming up to similar thalamic nuclei and then getting distributed to other areas. And then maybe auditory projections and other projections as well. So if you have lower peak alpha frequency, what I'm going to suggest that means is that there's more efficient thalamocortical signaling. And there's an easier path for pain and sensory signals to gain access to cortex. And that could potentially explain a lot of the hypersensitivity that we're describing when we describe COPCs. So raises a natural question: what can you do about it? Can you manipulate resting state PAF? Can you either temporarily or in a longer term fashion manipulate sensory sensitivity that may be resulting from this more efficient thalamocortical signaling? So when you look in the literature about people that have tried to manipulate PAF, there are some themes that emerge. So modification of attention will manipulate PAF. Vigorous physical activity will manipulate PAF, and manipulating the demands of balance will also manipulate peak alpha frequency. You can probably see where I'm going with this. couple of years ago, I came here and gave a talk at this conference, and I talked about a little study that I was starting about the therapeutic benefits of surfing. And it was a small study that I got funded from the Southern California Clinical and Translational Science Institute, our CTSI. And it was just getting the study launched and up and running. It had two parts, one to see if surfing was beneficial in the real world, out in the environment, but it also immediately acknowledged that this was not an intrinsically scalable activity. I couldn't move the ocean into the clinic, but I decided I wanted to move the ocean into a clinic, and so I designed a virtual reality version of this that I'll show you. We deployed this in a pilot study that I'm going to report to you today, and I'm really excited about it. So the background of this was about 2017, 2016. Somehow I decided to go in the water and start surfing. And I got out of the water, and it was a shocking experience that all the pain was gone. Yeah, okay, that's kind of cool. And did it again. All the pain was gone. That's weird. And so sort of time after time, no matter how high the pain intensity was, when it came out of the water, there was no pain. This has been described before in the famous documentary Step Into Liquid. An individual suffered a spinal cord injury and had neuropathic pain after that, basically articulates the same experience. No matter how much pain he was in, he would come out of the water in no pain. Paul, who's here today, can attest to this. So around 2017, we were at a neurocontrol movement meeting in Ireland. And I said, oh, Paul, I rented a car, which was not a good idea because they drive on the other side of the road. I want to go surfing on the coast. Do you want to come with me? Because I could really use somebody that knows how to drive on this side of the road. And so he came along and we went surfing. He went for a great run, and we also explored the Cliffs of Moher, which you may know from The Princess Bride as the Cliffs of Insanity. It was a wonderful time, but I was so intent on going surfing because I was just starting to realize the therapeutic benefits. I brought my skepticism as a scientist and said, I'm grateful that I have this thing. Maybe it's just my thing, but I don't think there's anything to study here, and I don't want to make too big a deal about it. But then I came into contact with this developing field of surf therapy that's been applied for a range of different conditions. The most influential piece was actually this documentary on Resurface, a documentary on Netflix, which is called Resurface. And it's about the application of surf therapy to veterans who were suffering from PTSD, trauma, amputees, et cetera, and kind of the transformative experience that they were having. There's also some very good books about using surf therapy to treat addiction, which is The Drop. And then surf therapy applied to autism spectrum disorders is covered in that last book by Cash Lambert. So I'm not here to say today that that surfing is completely unique. It probably lives at this intersection of activity that has some nice benefits that are kind of wrapped into one. You have good cardiovascular activity, you're maintaining balance, and it is in a highly dynamic external environment which helps modulate attention and probably pulls it away from pain. And like I said, I don't think it's totally unique. I think it sits there in a broader class of physical activities that have these kind of core elements of not only allowing you to be more active, but being more active and not have to think about it, not have to think about the pain, have kind of distraction built into the physical activity, and that there can be some very special things that might happen in that case, and that hopefully what we could do in the long term is to design VR experiences around these that can be adapted to various ability levels and help people take advantage of some of these things. Okay, so here's the preliminary study we did. These were all urologic chronic pelvic pain patients that basically would have met criteria for MAP, except for one thing. To get into the study, I required that they had to have at least one additional COPC. Didn't matter which one, it just had to be one additional COPC. There was really good interest in the study. We screened up 20 people, enrolled over half. and then 2 had scheduling conflicts, so they didn't actually even start the study. But all 9 that started the study completed it, and I think really enjoyed it. So here we did 4 weekly sessions at in the ocean. And here, the colors are individual people repeated across those multiple sessions. And you can see there was quite a substantial and quite a reliable drop in pain that was occurring across those sessions. Here's the overall estimate of where they started before a session and where they ended after a session. I acknowledge this is an uncontrolled study, but we wanted to do at least some preliminary evidence that there might be some specificity to the effects. So in a couple of the sessions, we asked them what their pain level was when they first showed up at the beach and before they got in the water, where they're doing things like interacting with the surf therapists and maybe putting on their wetsuits and talking to each other. And they're in this beach environment to make sure that it wasn't just a non-specific effect of being in a nice place like the beach. And there wasn't any change in pain in either of those 2 sessions that we tested that in. And then we also, in a second cohort, we did this sort of in 2 cohorts. There was a first group of 4 and then a second group of 5 patients. In that second group of 5 patients, we gave them a retrospective questionnaire when they came out of the water, asking them, if you did feel pain relief, when did you start to feel that pain relief? And the vast majority said after they got in the water, when they were sort of waiting for the first wave. So when they were basically engaged in the activity. So this is the effect that we saw in the ocean. And then here I'm going to say a little bit more. 3 to 6 months later, as we were building this prototype virtual reality surfing simulator, we had all 9 of those patients came back. They were at, fortunately, a little bit lower pain level even at the beginning, but in the VR surfing simulator, there was an additional significant drop in pain. Okay, so what I think is really interesting about this data is that here it can see all of the responses from all of the individuals. The individuals ranged in age from in their early 30s to early 60s. And if you look at the global response assessment, 6 of the 9 said that they were either slightly improved or moderately improved by about 4 weeks of therapy. 3 said no change. 1 said slightly worse, but they also said that they were very likely to continue surfing. And so I think that underlies the kind of like, we're doing this study in a realistic way on top of other fluctuations that are going on in the condition. And so what we did was looked at just a very simple initial kind of preliminary check, and we basically wanted to compare these individuals that had slight improvement versus the ones that had no change or slightly worse. So we compared them by age, no significant difference. We compared them by baseline pain, no significant difference. Compared them by symptom duration, no significant difference. Compared them by improvers versus, by number of COPCs in the improvers versus the non-improvers. And there was a huge effect of the number of COPCs, where the people that were likely to improve had more COPCs on average than the individuals that were less likely to improve. So this kind of attention modulation or immersive activity type of approach might be particularly important for individuals with COPCs. Here's one example, participant feedback. 44-year-old female had pelvic pain for 23 years and via the COPC screener had 8 COPCs. Though what you see on the left side there are comments that are related to the surf therapy in the ocean. And what you see on the right is comments related to her experience with the VR. So the VR was just a single session. It was kind of a test of feasibility. And let me tell you a little bit more about the VR. So this is what the surfing simulator looks like in its current form. It sits on a commercial 6 degree of freedom motion platform, which is really critical because if you put on a VR headset and you aren't, and it looks like you're moving and you're not actually moving, you're going to feel very, very sick very quickly. And I guarantee you it will not be therapeutic. But if you, in the VR simulation, if you match the movements to what the person is perceiving, and we also have a fan that is coupled to both gusts of wind and will also couple to the speed of the board. So when you go on the wave, it'll start blowing in your face, and it really helps you perceive movement. You will feel that you're actually moving. And we tested this very carefully for simulator sickness, and we found very limited amounts of simulator sickness, and it was very acceptable, both in healthy controls. And we were a little bit tentative because we wanted to make sure that there was low simulator sickness in the patients as well, and there was. So what's interesting in the VR is that we can also do 64-channel EEG while we're doing the VR, which is a nice way of monitoring EEG signals. That's kind of hard to do at the beach. And the other interesting thing is that we can adapt it. So we can, if a person wants to stand, that's great. But if a person wants to do it seated, we can fix a chair to the board, and they can still engage in the experience from a completely different posture. So we can very much, I think, adapt it to the ability level of the individual. We've just started to do some preliminary testing, so I'll say this is quite preliminary, but I'll give you a flavor for where we're going next. In the literature related to activities that can change peak alpha frequency, there's not a lot of detail about that you would want to know. Like, how long does the change in peak alpha frequency last? What are the dynamics of the peak alpha frequency change? So with this paradigm, we can really carefully monitor peak alpha frequency changes at 20-minute increments, and then all the way up to an hour after the surfing. So here is the 40 minutes of the VR surfing. This is to give you some sense for what we'd expect from baseline. These are what you would expect for the distribution of healthy peak alpha frequency values. The red are the ones that you would expect for pelvic pain plus COPCs, and this one would be with more localized pelvic pain. So what interestingly we see is drops in peak alpha frequency for individuals that have baseline high peak alpha frequency. There's some variation in the degree of that drop, but you can see that during the VR surfing there's a drop in peak alpha frequency, and then it comes back up and goes back up to its baseline. So you said, oh, that's kind of weird. I thought you told me that low peak alpha frequency was bad and high peak alpha frequency is good. Well, it just so happened that we struck on one otherwise healthy individual who happened to have low peak alpha frequency. So you might imagine that this is an individual that might have certain susceptibility to chronic pain, but doesn't actually currently have chronic pain. And so this individual came into the lab, and their peak alpha frequency didn't change very much during the surfing. But after the surfing, it went up substantially. It bounced up a lot. And here's a zoomed in version of that. This was during the VR surfing, and then up a lot. Now, if you compare this to Dave Semenovich's studies, this change in peak alpha frequency of half a hertz would be the difference between having 8 out of 10 pain for a provoked stimulus or having 0 out of 10 pain for a provoked stimulus. It's a massive change. Now, like I said, this is not a person that has pain, but just to give you a sense of the scale of the peak alpha frequency change that's induced, and it is an increase in peak alpha frequency. It's very promising. We're like, oh, that's kind of weird. Maybe this was just a fluke. So we had that same person come back. And their peak alpha frequency was higher when they came back. I don't want to make too much out of that. What I do want to say is the change was exactly the same. So it bounced up again afterward, just as it did before. Okay, so obviously we have to do a lot more testing here, but I think we want to say, what do we think is going on? All right, so what's a theoretical model? So let's say that I'm a person that otherwise has high peak alpha frequency. So before I start any VR, I'm going to say that my cortex is relatively disconnected from my thalamus. I'm not getting a lot of extraneous sensory or pain signals coming up. But when I do turn on the VR, I'm going to have a lot of visual input. And that's probably going to start streaming through my thalamus to my visual cortex. I'm going to be balancing or doing this other complex movements. I'm going to have somatosensory information going up to my sensory cortex. And then I'm going to have a lot of motor decisions. Let me back that up and make sure that that stays. Okay. Then I'm going to have a lot of motor decisions to make, which is engaging the anterior part of the thalamus for balance control. Okay, so right after I finish VR, I probably still have those connections. The input is going to go away. And all I want to suppose now for a moment is that in an otherwise healthy individual, there is some kind of homeostatic mechanism that will now start to disconnect the cortex from the thalamus because I no longer need to rely on that external sensory input. Okay? Now, what if I have low peak alpha frequency? Before I start the VR, I have no input, but I may have a stronger intrinsic connection between my thalamus and cortex, something that makes it easier for information to get from the periphery up to my cortex. Now I start the VR, and exactly the same thing happens. I'm driving a lot of sensory information through the thalamus. I don't see the peak alpha frequency go any lower, but that may just be because it's already kind of sitting at its floor. Now, they come out of VR. What if that same homeostatic mechanism is still in place? Then it could be that the peak alpha frequency will drift up as the cortex starts to disconnect from the thalamus. Now, maybe it doesn't stay that way because it will go back to that state of hyperconnection, but at least it's a modification. It's a mechanism by which you could modify the potential sensory sensitivity. You notice from all the pain data that I showed that the effect didn't last, right? When they came back the following week, they had high levels of pain again, and then the surfing would make the pain drop. They did show a general trend towards improvement over the course of the entire 4 weeks of the study, but of course it wasn't like a curative thing where you surf once and then there's no more pain. That lines up very well with my personal experience, which was that a big benefit of the activity was, as we heard yesterday from the patient perspective, taking control over the pain, finding something that could reliably and always have the effect that I wanted it to on the pain level. And that in and of itself was beneficial to start to reduce some of the anxiety related to pain. So I think even if these mechanisms are short-lived or short-term, they're still interesting to investigate because if they're reliable, they can be still put to good use for managing the impact of chronic pain. So future work and a quick summary. So I think hopefully I convinced you today that COPCs may be related to thalamic dysfunction. And what the upshot of that is that it allows a broader array of somatosensory and other sensory information to reach cortex and maybe cause some of the distressing symptoms associated with COPC. Activities that take advantage of rich sensory environments with goal-directed motor activity may be able to perturb that thalamic dysfunction and produce positive benefits. And we're really starting a whole series of future studies to link up the fMRI with the EEG to really try to pin down this mechanism in the thalamus, use that information to build better models for treatment response and non-response, and hopefully ultimately optimize activity-based interventions for chronic pain. And with that, I'd like to thank all of the funding sources, particularly the HEAL initiative for funding to really target COPCs in particular. Natalie McLean and Jason Charon, Rocco Calveri, and the other folks in the lab, and of course all the folks here that I interact with at CPFRC. It's just been an honor to be able to work with you guys. So thank you very much to everybody.